echocardiographic evaluation of atrial septal defect. So I don't have any disclaimer, and my reference has been taken from American Society of Echocardiography, Society of Cardiac Angiography and Intervention, and Journal of American Society of Echocardiography. So aim of this discussion is to know about the two-dimensional, three-dimensional colored Doppler echocardiography for the evaluation of interatrial septum, identify the parameters to characterize interatrial septum and its abnormalities, advantage of the echo modalities which are so far available, clinical and prognostic significance of the atrial septal defect and patent foramen ovale, septal aneurysm, and impact on chamber size, function, pulmonary circulation. Recognize the evaluation process of potential transcatheter closure and follow-up criteria after surgical and device closure. So these are the objectives. And now we should know what is an atrial septal defect. Atrial septal defect is a septal communication which is available in 6 to 10% among all congenital heart disease patients, and it is available in 1 in 1500 live births. 30 to 40% of the clinically important shunt in adult is atrial septal defect, and patent foramen ovale is present in 20 to 25% of adult. Atrial septal defect and patent foramen ovale is a significant health burden in pediatric, adult cardiology, medicine, neurology, and surgery population. So now we should know what is the component of the atrial septum. Atrial septum is composed of three components: septum primum, septum secundum, and atrioventricular canal septum. So you were seeing in this photo that this one is the atrial septal defect secundum type. Here in the atrioventricular canal part is the AV canal type, and this one is the sinus venosus type near the superior vena cava with the attachment of the atrial septum, and this is the inferior sinus venosus near the attachment of the inferior vena cava with the atrial septum. So these are the pictorial presentation. And what about the development of the atrial septum? Atrial septum usually, this is the normal right atrial view of the atrial septum. You can see the blue part here, and the red part is actually on the left atrial side. So when we view it from the left atrial side, we will see the septum secundum, but if we view the atrial septum from the right atrial side, we will see the septum primum mainly. So this is the blue part is the septum primum, and the red part behind is the septum secundum. So this is the embryology of the atrial septum. And as I have mentioned, septum primum drop from the atrial roof first, and then followed by the growth of the septum secundum. So first type of the abnormality in the atrial septum is the patent foramen ovale. It is not a true defect, but a potential space between the septum primum and septum secundum. The foramen remain functionally closed as long as left atrial pressure is greater than right atrial pressure. If left atrial pressure is less than that of the right atrial pressure, then there will be opening of the constant, this potential space, and there will be shunt through this space. Incidence in normal population is 27.3%. And stressed out PFO or stressed PFO is a PFO which is stressed, which is opened by stress and due to the change in the atrial hemodynamics, and thus creating a defect, and it is known as stressed PFO. So this is the patent foramen ovale and atrial septal defect which is here, and you see that this is the septum primum and septum secundum, and this is a space which can touch each other if the atrial pressure is higher than that of the right atrial pressure. But if the right atrial pressure is higher, then it will open and blood will move from the right atrium to the left atrium. So here it is visible. This is a constant space here, and this space actually remain closed only for the reason that left atrial pressure is higher than that of the right atrial pressure. But for any reason, if there is change in the hemodynamics, then there will be opening of this constant space, and there will be connection between these two atrium, and there will be from the right to left side, and there is chance of thromboembolic events. Then second type of the defect in the atrial septum is atrial septal defect, second num type. This is a deficiency of the septum primum tissue margin, and superiorly and posteriorly it is formed by the septum secundum. Anteriorly it is formed by the abicanal septum. Inferior margin is formed by the septum primum and left venous valve of the inferior vena cava. And size of this ASD may be circular like this one, but it may be elliptical or it may be round. So size is variable, not always it is like a circular one. And then now we can classify the second type of the ASD as virtual absence of the septum primum. There may be deficiency of the septum primum, there may be fenestration in the septum primum. So these are the three different types of the secondum ASD. And secondum ASD, if remain untreated, it can enlarge over time with age and cardiac growth. So a small ASD in course of time may convert into a very large ASD. So here again in the picture, you are seeing that this is the septum primum and this is the septum secundum, and in between is a large gap. This is the one ASD which is different from that of the patent foramen ovale. My slides are not moving, just a minute. Hey, Yara. Now, ostium primum defect. It occurs when endocardial portion fails to fuse, and it is also known as partial or incomplete avicanal defect. Then sinus venosus defect, it is not a true ASD, and it occurs due to the partial or complete absence of the sinus venosus septum between the superior vena cava and the right upper or middle and lower pulmonary vein. So superior sinus venosus defect is here between the sinus venous superior vena cava and the upper end of the atrial septum, and it may be like inferior sinus venosus between the inferior vena cava and the atrial septum. So in the echocardiography, you can see like this is a sinus venosus type of ASD. Now, unroofed coronary sinus is another type of abnormalities in the atrial septum. Here, the wall of the coronary sinus is absent within the left atrium or deficient, and it may be associated with the persistent left superior vena cava with coronary sinus and is known as Raghib syndrome. Redundancy. So now we are talking about another type. So far we have discussed about the septum primum, septum secundum, then ostium primum, and now it is another kind of defect which is atrial septal aneurysm. Redundancy or secular deformity of the atrial septum and is associated with the increased mobility of the atrial septal tissue. So this is a secular type of the deformity, and if the excursion of the septal tissue is more than 10 millimeter of the atrial septal plane, then it is known as atrial septal aneurysm. Prevalence is 2 to 3% among the general population, and these kind of defects are associated with the patent foramen ovale, cryptogenic stroke, and because of the passage of the thrombus from the right heart to the left heart, there is chance of embolic events also. Yeah. Then another type is Eustachian valve and Chiari network. This is the remnant of the valve of the IVC that directs the blood from the IVC to the left atrium in fetal life. Its significance is large or prominent Eustachian bulb with PFO contribute to paradoxical embolism, and Chiari network is a remnant of the right valve of the sinus venosus. Its incidence is 2 to 3%, and this is associated with the patent foramen ovale and atrial septal aneurysm like that of the previous one, that is Chiari network. Now, parameters to be evaluated for the atrial septal defects are: first one is the detection and qualification of the size and shape of the atrial septal defect, followed by assessment of the rim and the surrounding defects to ensure whether device closure is possible in this patient. Then degree and direction of the shunting, whether it is left to right shunt or right to left shunt, and change and remodeling in the size and function of the chamber. We know that in atrial septal defect, there is dilatation of the right atrium and right ventricle and is associated with the dilatation of pulmonary artery also. But sometimes this change, when there is Eisenmenger change in the patient and there is severe right ventricular hypertrophy in those situations. Now, we have to know about the pulmonary circulation also to know whether the pulmonary pressure is normal, especially for the adult population with atrial septal defect. They have high pulmonary artery pressure in most of the cases. So you need to know whether the pulmonary artery pressure is normal or not. Then field of the application, like in the clinical practice, we can apply it. And also we can apply it during the closure and others. So how we will evaluate the atrial septal defect? Especially we evaluate the atrial septal defect by 2-dimensional, 3-dimensional, and color Doppler echocardiography. And the echocardiography modalities are transthoracic echocardiography and transesophageal echocardiography. And nowadays, even intracardiac echocardiography is available. And during the device closure, many advanced laboratories that take the assistance of the intracardiac echocardiography. So this is the transesophageal echocardiography. Some of the photographs, you can see here that this is the atrial septal defect. This is the atrial septal defect. This is the left atrium. This is the right atrium, and in between is the large atrial septal defect. Here also, and this is the TE probe here, and this is also this is left atrium and right atrium, and so from all this picture you can see whether how the transesophageal echocardiography photographs look like. Now, imaging of the interatrial septum. If the patient's body weight is less than 35 kilogram, then transthoracic echocardiography is used for establishment of the diagnosis, but transthoracic transesophageal in intracardiac echocardiography can be used during the transcatheter closure procedure. But transthoracic echocardiography is used for the follow-up of these cases after device closure, even after surgical closure. Then the pediatric population more than 40 kilogram, we can use transthoracic, transesophageal, 3-dimensional or 2-dimensional for diagnostic workup. But for the transcatheter closure procedure, even in the operation theater during the closure, surgical closure of the ASD, we can use transesophageal echocardiography by using 2-dimensional and 3-dimensional mode. Again, for the follow-up of this group of patients, we can use transthoracic echocardiography. In adult population, diagnostic workup, we can easily use transthoracic, but if the echo window is poor, we can take the help of esophageal echocardiography even. And for the transcatheter device closure procedure in the adult population, TE is better than that of the TTE or transthoracic echo. For the follow-up, transthoracic echocardiography is useful even in adult population. Now, role of the echocardiography in device closure. Starting from the patient selection for procedural guideline in real-time mode, assessment of the device efficacy, and then checking of complications during the procedure, after the procedure, and in the follow-up, this echocardiography examination is the gold standard. Now, transthoracic echocardiography, what are the advantages? It provides information about the type of the defect, hemodynamic significance like the amount of the left to right shunt, and then if there is any associated pulmonary hypertension or not, associated other abnormalities with this defect like patent ductus arteriosus ventricular septal defect, and it offer unlimited multiple planes. So multiple planes can be achieved by doing this examination, and it can be repeated as many times as possible because there is no radiation hazards in this examination. And then the lower rim of the interatrial septum is not very nicely visualized with the transthoracic echocardiography. So this is one of the disadvantages, that lower rim cannot be seen clearly like that of the transesophageal echocardiography. Most important thing is no sedation is required, and it is readily available even in the bedside, even in the operation theater or anywhere, because this machine is portable and can be moved. So transesophageal echocardiography, what is the advantage of it? It is a real-time, highly detailed imaging of the interatrial septum and its surrounding structure. Then the devices, evaluation of the devices is possible very clearly, and it need conscious sedation or general anesthesia. This is one of the disadvantages, and so we try to actually avoid this in children, only for the complications which may arise from the sedation or from the general anesthesia. Even there is chance of aspiration in the adult population. There is three-dimensional TE probe also, which enhance the evaluation by clearly defining interatrial septal anatomy, superior visualization of the wire, catheter, device, and the relationship with the adjacent structures during the intervention procedure. Now, transesophageal echocardiography is superior than that of the transthoracic echocardiography, and there is no doubt about it. But even then, transesophageal echocardiography is not always required, and we can clearly avoid it in children because the chance of complication is more in children. Now about the intracardiac echocardiography, advantage is image quality not identical but similar to that of transesophageal. Comprehensive assessment of interatrial septum is possible. Location and size of the defect, especially in case of the multiple defect, it is very useful. And then ream assessment is very good. Location of the pulmonary vein and inferior and interatrial septum lower part analysis is very good with this modality, and there is no need for the intubation or general anesthesia because this can go through the femoral veins. Now, disadvantage is view is limited. Catheter stability and torque control is sometimes difficult. It is very expensive. Single probe is like 1,000, I think like 1,000 US dollar, and extra training is required to manipulate it, and it can provoke arrhythmia during the procedure. Now, transcranial Doppler. This is another kind of Doppler study. It is alternative imaging method for detection of the patent foramen ovale. You know that patent foramen ovale, it is actually not readily recognized in normal echocardiographic mode with the transthoracic and transesophageal echocardiography. So sometimes some extra manipulation is required in case of transcarotid Doppler. We can put the Doppler over the carotid artery, and then we can take the records of the CW over the carotid artery, and from that we can recognize the noise, and we can identify that if there is any patent foramen ovale, and we can do the Valsalva maneuver at that time, and it can provoke right to left shunting through the patent foramen ovale and help identifying the patent foramen ovale in this way. Now, there is a new diagnostic test for the PFO, which is known as transcarotid Doppler. It is a test to exclude right to left shunt through the patent foramen ovale. And in this procedure, Doppler is placed on the carotid artery, and then bubble is introduced through the cubital vein with a syringe, and more than 10 bubble in one Doppler envelope is considered as positive for presence of patent foramen ovale. So this is the transcarotid Doppler. You are seeing here that the Dopplers are visible over the envelope of the CW. And if it is more than 10, then it is significant. Now, role of transthoracic echocardiography in procedural guideline. So what are the views we can take for the transthoracic echocardiography? We can take sub-Gifford long axis or long axis frontal view, then sub-Gifford short axis view, 4-chamber view. And for all these views are actually very good for assessing the implantation of the device during the transcatheter closure. Now, the role of the transesophageal echocardiography in device closure procedure, you are seeing that various views are used for assessing various part of the heart and its relationship with the device. Now, basal transverse view. Basal transverse view is available at 0, 15, and 30 degree of the mid-esophageal or upper esophageal position, and it can actually assess the device and its relation with the roof of the atrium. So, and along with the device, it can assess the superior vena cava, right upper pulmonary vein, and the superior aortic rim. Then we can achieve 4-chamber view if we push the probe little downwards, and and if we rotate into 0, 15, and 30 degree view, then we will see the device and its relationship with the atrioventricular valve. So this is called 4-chamber view in the transesophageal echocardiography. Then if we can achieve short axis view in mid upper esophagus in 30, 45, 60, and 65 degree rotation. And device relation will be available here with the aortic valve and the posterior aortic atrial valve. So short axis view is good for assessing the relationship of the device to the aortic valve and the posterior aortic valve. Then we can achieve the bicaval view in the mid to upper esophagus in 90, 105, and 120 degree rotation. And it will able to analyze the device relationship with the right atrial roof. Then we can go to the long axis view in the mid to upper esophageal position in 120, 135, and 150 degree rotation, and it will see the relationship of the device with the left atrial roof. So in this way, by basal transverse 4-chamber short axis bicaval and long axis view, we will be able to analyze the position of the device with all the parts of the atrium along with the atrioventricular valve and the aortic valve. So what is the summary of the evaluation so far? We can see what is the type of the ASD. Then we can see whether it is an ASD or a PFO, or it is a primum, secundum, or unroofed coronary sinus, and if there is any association with the anomalous pulmonary veins. In the Doppler, you can see whether it is a left to right shunt, or it is a bidirectional, or a right to left shunt, which will indicate that this patient already developed pulmonary hypertension. Now, presence or absence of atrial septal aneurysm is very important because atrial septal aneurysm is associated with the stroke, and association of the associated findings like Sturgeon valve theory network and other congenital heart disease like atrial septal defect, ventricular septal defect, or some complex kind of heart diseases like tricuspid atresia, pulmonary atresia, or like transposition of great arteries. And we can also assess the size of the ASD, whether it is a large one or a medium one or a small one. And we can also measure the circular index to see whether it is a circular ASD or it is an elliptical one. And we can also assess the location of the ASD in the septum, whether it is a primum, secundum, or sinus venosus type. And we can also at the same time evaluate the rim. So what are the rims? Actually, there are 6 rims, and we have to evaluate all these rims very carefully before doing the device closure or before planning for the device closure. So aortic rim, superior rim, inferior rim, posterior rim, and I will show you the details of the rims in next part of my presentation. And about the shape, I have already mentioned that as ASD may be round, oval, or irregular in shape. ASD may be single, multiple, or fenestrated. And ASD is having a very dynamic nature, and size and shape change during systole and diastole. In device closure procedure, it is actually very good to measure the size of the ASD by stop flow diameter with inflation of the balloon inside the ASD, which we usually do, especially for the large ASDs. And at the same time, we can measure the RB and LB, systolic function, diastolic function during evaluation. So this is one of the photograph of the ASD here. And so this is the inferior rim and this is the superior rim, and this one is the atrial septal defect, and this is with the color. So color is crossing from left atrium to the right atrium. About the shunt identification, left to right shunt is usually identified in the color Doppler echocardiography, and bidirectional shunt is usually detected by the color flow and also by the PW Doppler. And patent foramen anomaly may not be identified by the color flow even if it remains stretched open. Sometimes contrast with the agitated saline is required, and and with the provocation of the raised right atrial pressure by using Valsalva maneuver. Transconnected Doppler can identify patent foramen ovale. RB dilatation is easily actually available, and we can measure the RB dimension, and QPQS calculation can also be done in the echocardiography machine with the help of software. So this is one of the atrial septal defect. This is a video and not moving actually. So this is atrial septal defect. We are seeing the right side of the chamber of the hearts are dilated. This is another one. Oh. So here, this echocardiography was recorded during a device closure procedure, and you have seen that this was the original ASD, and after measuring all these things, we place the device. Now, rim assessment, which is very important for the ASD device closure. Rim length of 5 millimeter or more is considered as favorable for device closure. Less than 5 millimeter usually is a very difficult case and usually contraindicated. So less than 5 millimeter rim is considered as deficient rim. So here you are seeing this is the atrial septal defect and this is the atrial septum, and all these colorful pictures is representing the various rims of the atrial septum. And I will show you later in other photographs. So less than 5 millimeter, as I have mentioned, is a deficient rim. And this is actually a 90-degree bicable view. And you can see that in this bicable view, you can see the atrial septal defect from top to bottom. We can measure the length from top to bottom. And this one is the mid esophageal 4-chamber view. And here is the one this is another view, is aortic short axis view. So in this view, we can measure the aortic rim. In this view, we can measure the atrioventricular valve rim. Now, I have mentioned earlier that there are 6 rims in atrial septum if we consider the device closure. Now, what is aortic rim? Aortic rim is the anterior superior rim between the atrial septum and the aortic valve annulus. So it is so in the anterior part of the atrial septum, there are this anterior rim is divided into anterior superior and anterior inferior. Anterior superior is the aortic rim and anterior inferior is the AV valve rim. In posterior side, it is also again divided into 3 parts. Posterior superior is the superior vena cava rim. Posterior inferior is the inferior vena cava rim, and directly posterior is the posterior rim, which is between the atrial septal defect and the posterior atrial wall. Another rim is right upper pulmonary vein rim, which is between the ASD and the right upper pulmonary vein. So these are the 6 important rims, and you can see here in the photograph that how these are looking like. So right upper pulmonary vein, this is the topmost one. And in the posterior side, I have mentioned that there are 3 rims, superior SBC, IBC. and posterior, and anteriorly there are two, anterosuperior aortic rim, and the anteroinferior is this AV valve rim. And IVC rim is actually directly inferior, and right upper pulmonary vein is directly superior. So these are the rims, and by the hand you can, if you use your hand, hand can represent the rims like this way. So this little finger, and then this ulnar side of the hand is the aortic rim, and the IVC rim is the thumb side, and the thumb is the posterior rim, and the index finger is the SBC rim. So in this way, you can memorize how to remember atrial rims. Yeah. So this is another video taken from the cath lab during the device closure procedure. You are seeing that this is a large ASD, and then this was measured, and this is another small ASD. So these are different kind of ASDs. Now, having adequate superior, inferior, and anterior rims are crucial for successful device closure. Deficient aortic rim is a potential risk for aortic erosion. And what is circular index now? The round or circular index, if you divide the maximum and the minimum diameter, then if it is less than 1.5, it is round ASD. And if it is more than 1.5, this is an oval ASD. So it is known as circular index. This is the video of a device closure procedure. I think everyone know about it, so I'm not going to the detail. Yara. So this is the balloon sizing procedure, and this one is the balloon. So we are measuring the ASD here. You can see that waist appeared here, and during the device closure procedure, we measure with the balloon the diameter of the ASD, and now here we are matching this balloon with the, this one is a measuring plate, and we are measuring the diameter here. These are different diameters, and we are adjusting that one with this one. Suppose this one here is 10 millimeters, so this one is 10 millimeter, like this. Now, this is the we are discussing about the procedure of the device closure. We should place the delivery system to the left upper pulmonary vein, then we should place the wire and dilator, and we should do all those things accordingly. Those who are interventional cardiologists, they know how to do it. Now, this is the video. So this is the delivery system in the left atrium. We are releasing the left atrial disc, and now it is coming down to the atrial septum. Now it is tightly attached with the atrial septum, and now the delivery system is coming first to the right atrium, followed by the release of the. So if we took it down, if we take it down, it will release the right atrial disc. So now this is the right atrial disc, and the other one was left atrial, and now the cable is released, and delivery system and cable will take it out later on after releasing the device. So this is the procedure of the device closure. We can see it from the TE also, and this is the TE guided device closure. You are seeing that this is a atrial septal defect already closed with the device, and this is the device here. So this one before closure and this one after closure. This is a case of patent foramen ovale closure. This patient was a 26 years old girl, and there was history of stroke, and we closed her ASD with the PFO occluder. So you can see here that the PFO occluder is used. And what is the difference of the PFO and SD occluder? PFO occluder, the left atrial disc is smaller than that of the right atrial disc, because in this kind of patient there is right to left shunt and there is chance of stroke. So we give right atrial disc larger than that of the left atrial disc. Now, what are the acute and chronic complications of the device closure? There is chance of cardiac perforation and tamponade and death. There may be device embolization, but retrieval of device is possible with the hardware available like snare catheter. If not available, then we can refer the case to the surgeon immediately. They can retrieve the device and at the same time they can close the ASD. Bleeding is one of the major complications, so transfusion or surgery is required if there is puncture, cardiac perforation. Sometimes cardiac perforation may heal spontaneously if we can do the auto transfusion and pericardiocentesis and auto transfusion. But sometimes this kind of patient after perforation they need surgery. Pulmonary embolism is another complication, and anticoagulation is required. Device erosion and surgery is also. If there is device erosion, erosion happened at aortic root and surgery is required in those cases. Infective endocarditis is another complication, and device fracture. Sometimes there is device fracture, and in those cases there should be removal of the device and surgery. We can do the follow-up of these cases with the transthoracic echocardiography, transesophageal echocardiography, and we should do the ECG to look for the heart block, arrhythmia, conduction abnormality. We should do the follow-up at 1, 6, and 12 monthly interval and thereafter. So this is the T with device inside too. You are seeing that how the device looks like. And in my center, we do our patient selection with the help of transthoracic echo, and we use minimalistic approach because Bangladesh is a resource constrained country and trained manpower is not available in all the places. So I do the procedure in minimalistic approach where I don't use in most of my cases transesophageal, don't use like detailed diagnostic procedure. So we do all the evaluation with the transthoracic echocardiography, straight we go to the device procedure and we finish it quickly. And we don't do T unless there is very poor echo window. So in conclusion, transthoracic echocardiography is the least invasive modality of percutaneous closure in minimalistic approach. Transesophageal echocardiography provides detailed imaging of the atrial septal defect. Intracardiac echocardiography is alternative for transesophageal echocardiography. And regardless of imaging type, PREM assessment is mandatory for device closure. Balloon sizing is recommended before closure for all the large ASD cases. And in our center, we use this protocol. Careful imaging guide is mandatory at all stages of the device placement. Transthoracic echocardiography should be performed before discharge and repeated in 1 week time. And follow up at 1, 6, 12, and a month interval and yearly thereafter up to minimum 3 years is mandatory. And afterwards as and when required. So thank you very much for patient hearing. And that's all from my side.